Hyo Kyung is finishing her PhD at the University of Wisconsin in the Industrial Engineering department. And she's going to talk to us today about work that she's doing in transition into care. Hyo Kyung has a lot of experience working with providers, working with Mayo, University of Wisconsin, and so on. And so we look forward to your presentation.
Thank you so much for the introduction. And also thank you for inviting me to the campus. I'm really enjoying my time here. And I'm really excited to talk about my research, so I hope you also enjoy listening to my talk. So my talk is on the operational decision-making across the patient care cycle. So as all of you already know, the US healthcare costs are increasing rapidly each year, and this is creating pressures on the healthcare providers to cut down the cost while improving the care qualities. So as one of such efforts, the US healthcare system is currently shifting from the traditional volume-based, the fee-for-service, towards a more value-based care and payment model. So basically, they're trying to link the patient outcomes and the care quality to the payments the physicians or the hospitals receive. So they're trying to incentivize the providers to improve their care quality. And due to such widespread movement towards a value-based care payment model, we can no longer just focus on the hospital or the acute care providers only. Because throughout our lifetime, we are not only treated inside a hospital. We go to the primary care clinics, we go to specialty cares, some outpatient care. So in order to really maximize the patient outcome, we have to look at this entire spectrum. So this means all the different provider segments have a more growing role to play in improving the patient outcomes. And based on these motivations, my research interest is to look at this health continuum, and more specifically, the patient care cycle. So from like a more macro perspective, the patient care cycle refers to all the care activities a patient or an individual may go through starting from their birth to until their death. Because we as an individual continuously make decisions and continuously engage in activities that affect our own personal health. So throughout our lifetime, we will be engaging in one of the activities inside the patient care cycle. So typically, starting from a normal and healthy state, we will have some regular preventive visits to the primary care clinics to maintain our good health status. And once we develop some kind of illness, we will go through some diagnosis procedures to confirm our disease stage and also determine the most appropriate type of treatment. And during the treatment, we can either be treated inside a hospital or through some outpatient care clinic settings, whichever is more appropriate. And after treated, we will have some additional rehab services or home care visits to recover back to the normal and healthy state. So for all of these, for this kind of patient care cycle, the eventual objective is pretty simple. It's to maximize the proportion an individual spends in the healthy state. So we want people to be healthy. And this is equivalent to saying minimizing the proportions in all the other care activities. So basically, reducing the delays or inefficiencies the patients may experience throughout these stages, this will eventually contribute to delivering a more safe and high quality of care to the patients. So throughout my PhD, I have worked on various research projects, each looking at different segments within the patient care cycle. So just to give you an idea, I will briefly introduce some of the research topics. So for the prevention stage, I mainly focused on the improving accessibility to the primary care clinics, which is a huge issue. So I tried to look at what's the impact of implementing a new service model in the primary care clinics, which is called the joint visit model. And also I tried to look at what's the optimal workload allocation between the different care provider roles. And for the diagnosis phase, I collaborated with Baptist Memorial Healthcare to look at the lung cancer patients. So starting from their first abnormal chest X-ray or CT scan to until they finally receive the surgery, what kind of diagnosis procedures they go through, try to model this quantitatively to basically improve the overall efficiency. And for the treatment phase, I mainly focused on the inpatients inside a hospital and tried to look at the patient flow. So I looked at two different topics. One is looking at the transitions between the different departments inside a hospital, try to look at the blockings or congestions that can happen during these transitions. And the other one is working with Mayo Clinic. We looked at the rounding processes conducted at the intensive care units, try to model this and try to find a bottleneck to improve the overall efficiency. And for the home care phase, we mainly focused on the readmission problem and also tried to model the post-operative care process, mainly for the joint replacement patients and also for some COPD patients. So for all of these research topics, the goal was pretty much the same: improve the efficiency, quality, and safety throughout the patient care cycle. And to talk a little about how I achieved this goal, so this is my research interest, the patient care cycle, and my goal can be summarized into 4 specific points: improving accessibility to care, delivering a more personalized care, determining optimal capacity, and planning appropriate care interventions. And to achieve these goals, I use various data sources, so mainly the EHR system, the electronic health record system, and also some hospital administrative data for the cost analysis, and finally, through direct observations at the hospitals. So for my research, in the initial phase, we typically have multiple visits to the clinics to really understand their process, and sometimes collect some data that's not obtainable through the EHR system. And also by consulting or interviewing the physicians, we use their inputs as data sources as well. So using these data sources, I utilize data analytics or operations research methodologies, mainly stochastic processes, to analyze and model the system to deliver some kind of operational decision-making tool the healthcare professionals can use in their practice. So one thing I want to mention is, for all of my research projects, we have worked very closely with the medical collaborators, and actually most of the problems were originated from the hospital side. So we tried to solve their problem, and after appropriate modeling and analysis, we deliver the final solution. Sometimes we deliver the model itself or the framework or some kind of insights we obtain from the model, so they can use in their daily decision-making in practice. And in today's talk, due to time limit, I will only focus on 2 research topics, one looking at the treatment and the other looking at the home care phase. So without further introduction, I will start with my first research topic looking at the treatment phase. So as I mentioned, I'm focusing on the inpatient flow inside a hospital. So this is looking at the delays or congestions during these transitions. So this figure shows a typical patient flow inside a hospital. So you can see different departments like the ED, the floor, the ward, or the PQ. So this figure is obtained from a pediatric trauma center database. So PQ stands for pediatric ICU. So you can just consider it same as intensive care unit. And the arrows here indicate the patient flow between different departments. So as you can see, it's very complicated and it doesn't have a fixed sequence because patients can go to different departments depending on their health status. And also they can go back and forth, multiple units, different units multiple times depending on their health. And during these transitions, because the hospital has limited number of resources in each of the unit, delays or congestions can happen. Patient may need to transfer from, let's say, from the ED to the ward, but there's no resource available at the ward. Then they will be blocked, and they will remain in the ED. This is called ED boarding, and they will wait for an available bed. So what kind of delays commonly happen in many of the hospitals? So as I mentioned, the ED patients that needs to be admitted to the ward, from the medical literatures, it is known that about 1/4 of them have to wait more than 4 hours. And if you have ever been to an ED, you will probably be not surprised by the numbers. You know, waiting times are so common nowadays, but it's not, just because it's common, it's not saying that it's not right? We shouldn't be waiting that long, but we're just used to it. And the more severe ED patients that needs to be admitted to the intensive care units, about the average waiting time is more than 3 hours, which can be critical to their health status, right? And the ward patients, they may have a sudden deterioration in their health, so they need to elevate to the ICU. But it's known that about only 1/3 of the patients can be immediately admitted, which can have a serious impact on their mortality. And the ICU patients, on the other hand,
This is for one hospital or throughout the country?
it's typically like for a typical hospital.
So in general, it's everywhere. Same.
Well, yeah, I guess it's the average. You can say it's the average, yeah. And the ICU patients, because there's just so many patients that need to come into the ICU, these patients may need to be discharged earlier than they should have otherwise. And this is called ICU bumping, which causes serious impact on their care quality. So all of these problems are commonly observed in many of the US hospitals. And among different resources, we typically focus on the bed capacity, because hospital bed is one of the most expensive resources in the hospital. And it's the reasons of delays can be many things, but hospital bed can be one of the main reasons. So we focus on the bed capacities, and for the unit, we focus on the 3 major units: the ED, ward, and the ICU. But we are not saying that our model is confined to these 3 units. It can be generalized to any other units. This is for illustration. So this is the system that we want to analyze. And as I mentioned, transitional delays have a significant impact on patient outcomes. So there has been a lot of studies looking at such delays, where most of them are based on clinical or qualitative type of studies. So they try to assess the impact on patient safety or the care coordination issues, but not using an analytical model. And the analytical models that do look at these multiple departments are much more limited, because most of them, they typically focus on one single transition, like ED to ward. Or sometimes they focus on one department, typically the ED overcrowding issue. And the models that do look at multiple departments at the same time, what they do mostly is assume infinite capacities. So they don't directly capture the blockings. But in our study, the focus is on congestion. So we'll be using a finite capacity queuing network model to study such system. And among the different transitions here, the ones that complicate the analysis of such a system are these red marked ones. These are the inpatient flows inside. So to give you kind of sense why this complicates the problem, let's assume the ward becomes full. So all the ward beds are occupied. So now, the ED and ICU patients that needs to transit to the ward, they will be blocked, right? There's no bed available. So they will remain in ED and ICU, still occupying the beds there. And this will cause congestion in those units, because the patients, after treated, they have to come out in order to accommodate the arrivals of the new patients, but they are kind of stuck in the unit and they are waiting for the beds. So this will cause congestion in those units, and this will in turn lead to delays for the patients that needs to come into ED and ICU, because the patients are not coming out. So you can see that this congestion and blocking propagates throughout the entire system. And one unit capacity really impacts the overall system. And that's why we need to look at the multiple departments at the same time, because they are really interconnected together. And also, because we're considering a general routing with feedback flows allowed, we have to keep track of where the blocking is coming from. It's not like a tandem structure where we can just assume the blocking comes from upstream. For our case, the upstream can be ED or ICU. It can be multiple units. So we have to keep track of where the blocking is coming from. So all these problems make the analysis of such a system very complicated. And that's why the exact methods exist only for a very small system, like maybe some assuming like single server stations, or very simple tandem-like structures. So most of the studies, what they do is they use an approximation method. So they try to approximate the performance rather than deriving a closed form solution. And the main motivation for approximation is to reduce the dimensionality of the system so we can somehow analyze it, where the most commonly used approach is the decomposition method. So what's a decomposition method? It's basically decomposing the system into a set of subsystems and analyzing each of the subsystems independently. So if you were to use it for our case, we can decompose the system into ED, ward, and ICU subsystem. But because these subsystems are really connected together, the departures from one system forms the arrivals to other systems. So we have to consider the interactions. And by considering the interactions, we somehow modify the structural parameters of each of the subsystems. This is how we consider the interactions. And before moving on to our method, here are some of the existing methods, some of the pioneering works related to decomposition methods used in finite capacity queuing networks. And most of them are based on exponential service distributions or tandem or feed-forward structures. So there are existing models, but the problem is because we're looking at a healthcare system, we cannot directly use these models because the limitations that exist in these models can be critical in healthcare settings. So what are those limitations? So first, most of the models are based on Markovian. So they assume Poisson arrival rates and exponential service rates. But in hospital, the arrivals and services, they rarely follow exponential. And sometimes it's not even close to exponential. So we have to generalize the service distributions. And also, because we're considering a feedback flow, it's theoretically inappropriate to assume Poisson arrival rates in the first case. So we have to generalize. And second, existing models tend to use first come, first served policy. But in hospital, it's very common to observe that certain patients may have higher priority than the other patients. So we have to consider different priority rules. And lastly, existing models focus on the average performance, the average delay times. But first, variability causes congestion, right? Even though we have the same average, if we have a high variability, then we will likely experience more congestion. And also, more importantly, because we're considering a healthcare, a hospital, the entities here are humans, not products. So even though the average waiting time is small, if the variability is very long, that means some patients are actually waiting for a very long time, which is not acceptable, right? So in healthcare, we really need to understand the underlying variability to improve the patient safety and quality. So in order to study the patient transitions inside a hospital, we really need a holistic model that looks at multiple transitions at the same time while capturing the variability of the congestions and also considering more general arrival and service distributions and considering different priority rules, which is the focus objective of our study here. So in order to develop such a model, this is the main framework of our study. So it's a two-step iterative approach, so it may be a little hard to read. So I will explain each step in details in the upcoming slides. So first, to give you a rough idea of what each stage is doing, in the first stage, what we do is we approximate the waiting times for each of the inpatient transitions. So these colored blocks represent the queue times, the average and the variabilities. And using that, we go to step 2, and we modify the service rates of each of the subsystems. And what we are doing is we are adding the queue time to the original service time and calling that the effective service time. So why are we adding the queue time to the service time? Existing models, they don't really link the findings to to the care process afterwards. And the studies that do look at the post-operative care process itself is also very limited in the analytical side, because most of the existing models try to use like a clinical study or like pilot study kind of study. So it's mainly the medical literatures. So they try to compare, they try to look at the efficacy of a certain intervention program. So what they do is they typically focus on the early interventions. So right after surgery, they give some kind of intervention to a group of patients and they compare their outcomes to another group that didn't receive intervention. So this is the typical type. But the problem is, first, the outcome measures are not the same. So different studies use different measures because we don't really have a standard. So it's really hard to compare different intervention programs. And also, second, existing studies only typically focus on the immediate postoperative care process. But the CMS, they actually use a 90-day time period for penalizing TJR readmissions. So they look at the entire 90-day, and if a readmission happened, they don't care when it happened. They count it as the same. So readmissions, even though many of them tend to happen in the early days, some happen in the later days as well. So in order to really optimize the overall care process, we need to look at the entire time frame. So in this study, we tried to analytically model the postoperative care process, and we look at the entire 90-day care process. So this is the main framework of our study. So in the first phase, we developed some prediction models that can predict the patient's readmission score. So using 32 different risk factors, we developed a prediction model, and using that, we can stratify the patients into high, medium, and low risk. Then, in order to look at the post-operative care process, we consulted with the medical professionals at our collaborating hospital, and currently what they do is, after the surgery, they will have a pretty good estimate of how risky this patient will be. So based on the patient's progress during the hospitalization, they will determine the most appropriate type of location for their discharge. So patients can be discharged to different levels of care facilities, where typically most high-risk patients will be discharged to most high level of care facilities, which is the skilled nursing facility in our case, the SNF. And the somewhat medium group of patients, they will be ideally discharged home, but they will receive additional home care visits provided by the healthcare professionals. And the low-risk group patients, they will be just discharged home without any additional care, the so-called self-care. So we relate each of the risk group to their corresponding ideal care facility type, the SNF, home care, and self-care. Then we look at the post-operative care process for each group of patients. So one thing to clarify here is, intervention is not the direct treatments or medications. It's the additional supports provided by the hospital. So it can be some simple things like conducting phone calls, or it can be having the patients visit the clinic to have a checkup like in 2 weeks, 6 weeks, 3 months, or it can be the physical therapy visits, so they can recommend the patients to go to PT to exercise, or they can have some additional nurse visits to check on the patient. So it's additional supports provided by the hospital. So we look at what interventions are provided and when they are provided to the patients to basically find the optimal intervention policy. So here, the policy is optimal in terms of the total cost. So we try to minimize the total cost incurred during this entire 90-day period. And we specifically look at 3 different costs. So one is the cost of providing the interventions. Second, we look at the cost incurred by the patient staying at the care facility. So in accordance to intuition, intense level of care facilities will be more expensive. So SNF will be more expensive than home care more expensive than self-care. And lastly, we directly capture the readmission penalty. So we keep track of whether the patient readmits or not. And at the end of the time frame, planning horizon, we impose readmission penalty to the patients that gets readmitted. So we look at 3 different costs. Because if we don't consider intervention cost, ideally, it'll be like readmissions would be lowest if we give interventions to all the patients throughout all the time. But in many cases, this is not practical because of the cost. So we try to find the right balance between giving interventions or not giving interventions. And we find the optimal policy in terms of 2 aspects. So first, when is the optimal timing? During the 90-day, when should we give the interventions? And second, the optimal group. Among different care facility levels, which one should we target to be most cost-effective? So this is the main framework, and in today's talk, I will only focus on the post-operative care process due to time limit, which I think is more interesting. So this is the current intervention process conducted at the collaborating hospital. So as I mentioned, they have 3 different care facility levels: SNF, home care, and self-care. And currently, the hospital, they don't differentiate the patient groups. So they give the same intervention to all the patients. So what they do is they will typically give an initial phone call right after discharge within 24 hours to check on the patient. And if they feel that the patient is not doing well, they will give additional phone calls throughout the days. But typically it will be just one time. And also, they ask the patients to come to the clinic on a regular basis. So it's like 2 weeks, 6 weeks, 3 months, and so on. And lastly, they require the patients to go to the PT to exercise. So these are the 3 main intervention processes the hospital is conducting. But when we looked at the EHR data, and also when we consulted with the medical professionals, we found out that first, the initial phone call, this is given to all the patients. So it's like a mandatory policy for the hospital. So they give it to all the patients. And second, the clinic visits, it's very rare to observe a patient missing this clinic visit because we're not asking them to come every day, right? It's like 2 weeks, 6 weeks. So most of the patients, they come to the clinic. So the main difference between the patients were the PT exercises. Whether they went for PT or how many times they went for PT or when did they go to PT. So in our model, our main focus is looking at the PT exercises. So we try to model this using a finite state, discrete space Markov decision process. So here, this time epoch is defined as the number of days elapsed since discharge. So starting from the day of discharge to the end of the 90 days. And the state space here is defined as the care facility type the patient is currently staying at. And for our case, we have 3 different care facilities where the smaller number represents more 2 actions, give interventions or not. So we are basically trying to find the optimal action at each state for each time. And depending on the action, patients can have different transition probabilities. So basically they can readmit, or they can stay at the same care facility, or they can de-elevate to a lower level care facility. So de-elevation is what happens in reality because as patients recover throughout time, they will typically de-elevate to a lower level care facility. And elevation is very rare to observe in real case because it's more expensive, so it involves insurance issues. So it's typically more hard to elevate. So we only look at the de-elevation in this study. So, and we assume that less intense care facilities are associated with lower readmission rates, which is kind of already assumed in our framework because we assume high-risk patients go to SNF, medium, home care, low, self-care. So we're already assuming higher level care facilities have higher readmission rates. And we also assume that as patients recover throughout time, their recovery will increase. So this means their readmission probability will decrease in time and their de-elevation probability will increase in time. Because de-elevation is same as, basically you can think of it as recovery. So based on these assumptions and this modeling structure, we can prove these propositions. So I will not go through them one by one, but it's basically proving some kind of monotonicity. So what we want to say is, basically the total expected reward does not decrease as patients de-elevate to a lower level care facility or longer days have elapsed since discharge. So this basically means that as patients recover, their total expected reward will not decrease, which makes sense, right? And we can further prove this proposition, which is also regarding monotonicity, which gives us this final theorem. So this theorem says that there exists a monotone optimal policy. So for each decision epoch, the optimal action at the lowest level care facility provides an upper bound for the higher level care facilities. So it may be a little confusing to read it like this. So I will show you this result through a case study in the next slide. So this is the result of applying our modeling framework using the real data from the EHR system. So first, I'll explain how to read the figures. So it's all the same way, so I'll just look at the first one. So here, the x-axis represents the days since discharge. So this is the day of discharge, and this is end of 90 day. And the y-axis represents the care facility types. SNF, home care, home. And the colors here represent the optimal actions. So gray color is saying that the optimal action is to wait, not give interventions. White color, give interventions. So basically, each row here represents the optimal policy for each group of patients. So this is how you read it. So if you read this entire figure, this optimal policy is saying that for home and home service patients, you give interventions throughout all the 90 days. It's all white, right? But for the SNF patients, you wait until 40 days and then start giving interventions. So this is what the diagram is saying. And the difference between the different figures, so the top three ones, this represents different intervention cost. So how much it costs to give intervention to one person. And we only change the cost here, and the effectiveness of the intervention remains the same. So the left side represents less expensive, right side more expensive. So intuitively, the effectiveness is the same, but the cost is increasing. So as it gets more costly, it will be less cost effective to give interventions, right? So you can see that the gray region expands. And if you look at the bottom three ones, this is looking at different readmission penalties. So left side, less readmission penalty, right side, more readmission penalty. So you can see as the penalty becomes higher, the optimal region of intervene expands because the penalty is so high, it's more cost effective to give interventions to more patients to prevent readmissions. And if you look at all these figures, the optimal policy is exactly divided into two regions, right? Which basically shows the existence of the monotone optimal policy. So if you look at this last sentence again, the optimal action at the lowest level care facility provides an upper bound. So what this is saying is, for our case, the least intensive care facility is self-care, so this provides an upper bound. So if the optimal action at home patients is to wait, then the optimal actions at other facilities should be wait as well. So you can see this is true for all the cases. So that's what that sentence means. Okay? And lastly, one very interesting thing we found from the results is this immediate postoperative care period. Because as I mentioned, the medical literatures, they tend to focus on this immediate postoperative care process. But our findings, actually, the policy suggests that you should wait and then start giving interventions, which seems kind of counterintuitive, right? But one thing to clarify is we are not saying intervention is not effective during these phases. We are only saying it's less cost effective. It's still effective, but it's less cost effective. So we looked further into why this is happening, and we found one possible explanation in the causes of readmission. It's still a hypothesis, so we need to look into further. This is an ongoing project. So the causes of TJR can be divided into two cases, surgical or medical causes. So surgical causes are directly related to the surgery process, while medical causes are more related to the person's general health. And among these different causes, actually, many of them are not preventable. We can't really do anything. But the things that are preventable, these ones are the main preventable causes identified by the CMS. And while the overall readmissions, they tend to occur more in the early days, these preventable causes tend to occur more in the later days, the readmissions due to these preventable causes. So we can say that the current intervention process, it will be more effective towards the preventable causes. So they are more effective in the later days. So this is just one hypothesis that we are considering right now. So we are trying to look into, we're really trying to incorporate the causes of readmissions and try to see if this is correct or not. But this was a very interesting finding that we found. And we talked with the medical collaborators. So I think they also thought it was pretty interesting. So they are currently discussing to whether to increase their duration of the intervention program or not. So this was the second topic that I wanted to introduce today. So to summarize, this is my research vision as of current. But in the future, I believe the healthcare is transforming. So in the past, we focused more on the diagnosis, the treatments, or the medical products itself. And now we are focusing more on the platforms. So the EHR system will be a perfect example. And in the future, I believe that building on the current platform, there will be more advanced intelligence embedded to the system. So it can really provide some kind of solutions or decision support tools for the clinicians. So I believe, according to this trend, I believe the future healthcare research should be directed towards these 6 values. So we should be more patient-centric. We should include patient in the loop. And we should try to provide a more personalized care plan instead of just giving the same intervention to all patients. And we should try to provide a more interconnected and continuous care throughout the care delivery cycle. And instead of waiting for something to happen, we should be able to predict and be more proactive. So I'm still interested in looking at the patient care delivery cycle, but I want to look at, right now I look at each segment. I want to look at the continuing transition between the different segments. So this can be looking at the continuous and interconnected care throughout the cycle. And one specific idea that I have is looking at the post-operative care process. So for now, I use the readmission risk as the patient outcome. But what I want to do is, if I can collaborate with some biomedical engineering faculties and to integrate some kind of medical devices, and specifically the wearable devices, where patients can put on their knee or hip, so we can have a continuous monitor of a more objective functional measure. So we can kind of measure the gait speed, or how regular their steps are, or how fast it takes them to stand up. So we can measure all these things and try to predict if something will happen. If they have a high risk for fall, or we can even detect if someone actually fell, but there were no one in the home. So we can try to detect if there's any movement or not. So I want to integrate some medical devices to provide a more personalized, and we can be more proactive, and we can also try to predict if something will happen. So I think this will be a very good fit for NSF, Smart and Connected Health, for the federal agency funding. And also NSF operations engineering will be another good fit for my research methodologies in stochastic processes. And I will also continue seeking other funding opportunities in AHRQ or PCORI, which are healthcare federal agencies. And also, the industry is another potential source for funding. So healthcare industry, Baxter Healthcare is, we are currently working with them, and we are actually funded by them. So it'll be very good if I can continue my collaboration in the future to get some funding from them as well. And for the medical collaborators, I will, of course, continue my current collaborations with all the hospitals that I have been working on. So I just started a new project with Mayo Clinic, so hopefully I can bring this to Purdue if I come. And also Baptist Memorial Healthcare, which is in Memphis, Tennessee. We looked at the lung cancer project with them, so it'll be very exciting to continue our collaboration with them as well. And of course, I will seek new collaborators near the campus. So Indiana University School of Medicine, I will definitely try to find some way to connect. And also, the local hospitals near the campus will be a very good collaborator as well. Because the SSM Health and Dean Healthcare, they are local hospitals in Madison, and we have worked on lots of projects with them. So I will try to find some local hospitals. And I just wanted to thank my advisor and my collaborators in both the academic and the medical side. So yeah, just to acknowledge their contributions. And before finishing, I just want to mention my teaching interest. So because my research interest is stochastic processes and healthcare courses, so I will be very willing to teach some stochastic classes. Or I found the healthcare delivery systems, which is taught by Professor E. This was exactly the course I wanted to teach, actually. So I'll be very willing to teach this kind of class. And also, I use lots of simulation models to validate my analytical models. So simulation class is another class that I'm willing to teach, some undergrad level simulation classes. And lastly, I don't have manufacturing research background, but I have a teaching background in manufacturing. So last semester, I taught a graduate level course, Production Systems Control. So I'm willing to teach some intro level manufacturing classes. I have been a TA for some intro level, like where you teach how to use the CAD, how to use the NC machines, so I can teach them in intro level classes as well. And lastly, if I'm given the chance, I want to develop some courses that's more specific to operations research and also maybe some predictive analytics if there's lots of interest from the students. So what I want to do in the classes, if I can find some local hospitals, it would be really nice to have some student projects where the students can really work with the medical collaborators to understand their problem and try to, be a consultant. So I took one of such classes in my PhD, which was extremely beneficial to me. I learned a lot from the interactions, how to deal with the people in hospital. So it would be really great if I have a chance to develop such a course. So this concludes my presentation, and I'll be happy to answer any questions. Thank you.